Yeah, no, thank you. I actually requested this. It was my idea to do this because just so many questions, and with the surge and so much confusion and really misinformation, I thought, at least for our community, we could, have an honest discussion. I'm not going to lecture. I'm going to say about 3 minutes of stuff, of preliminary stuff, and then I'd really just like to ask questions. This is not political. I'd like to make this. I mean, this will be just factual, and I think it's going to be based on the best knowledge that there is right now. Let me just go ahead and ask everybody to mute their phones if they can.
I'm going to mute everyone and I'll unmute you, Pete.
Okay. Okay, that's good. Anyway, let me just say a few things, and then we'd like to just open it up for questions, because that's the whole point, is to address your questions and your concerns. So, as you know, I mean, COVID is real. It is a real and serious infection that's going berserk right now. If you just look at our numbers, the numbers that UAB and the numbers that you should all be familiar with, at the peak of the summer surge and in the spring, I think our maximum, maybe on any given day, was 125. We're at 160 today, and the hospital is anticipating as many as another 100. So we could be looking at anywhere from 250 to 300 COVID patients. These are patients who are sick. They're coming in because their oxygen saturation, or the amount of oxygen in their blood, is really insufficient to be at home safely. So to be admitted to the hospital, generally you're going to receive oxygen and probably some other treatment. Steroids or an antiviral. It depends on kind of what category you fall into in terms of your severity of illness. But it is real. What we're witnessing now is really what was predicted by everyone, and that is that, gatherings at Thanksgiving were going to lead to a significant increase or surge in cases. This is exactly what's happened. It happened after Thanksgiving. I mean, it happened after Labor Day and after 4th of July. It will happen again after Christmas. And so, all the public health people can do is urge people to either stay apart, or if they are together, then to follow some rule. And the rule really is, the kind of the 3 W's. Wash your hands, wear a mask, watch your distance. And so it's really distancing, wearing a mask, and then frequent hand washing. If we were all doing that, if we'd all been doing that all through this whole epidemic, we would be far, far better off than we are now. But for whatever reason, we just, for a number of reasons, we have just not adhered to those standards, those recommendations. And so this is where we are. We lay the blame at any number of people or individuals' feet, but at the end of the day, we're responsible. I mean, we as individuals. I've said before, and I think it is very much true, that, wearing a mask, for instance, is a responsibility, and it's an act of love directed towards your fellow man, for your family, for people that you don't know. And, I think all the public health data suggests that, that wearing a mask is really, really important. So these are the types of things that I think are not arguable. The data supports it. Those who choose not to believe it are free not to believe it. But fact is, that is kind of where things sit. We have a vaccine. This is in the news now. And there are going to be a lot of questions about the vaccine. I can provide you what data that there are relative to its efficacy, what we know about safety, and I can give you a synopsis or kind of a snapshot of how it'll be rolled out, which will affect a lot of people in our community. So that's really all I want to say, Father. And so I would, there were 4 questions that were mailed in or that were sent in before, and I can go ahead and address these. And I suppose, Father, if you want to unmute folks, go ahead and do so now. And then I'm going to address these questions, which I think are going to be asked by a lot of people. And so it may save some time just to address these questions first.
Okay, that sounds good. And
okay.
Everyone, you'll have to unmute yourself if you have a question. If you want to raise your hand on the Zoom feature, then I can line up the questions and call on you.
Okay. Yeah, that would be good. So, Father, if you can line them up and read it, that would be great. Okay. So, question 1: do you think it's safe to get the vaccine? This is going to be a question a lot of people are asking. One of the problems with rushing through a vaccine, one of the features of vaccine development is that you follow people for months and months and months, sometimes 6 to 12 months after a vaccine has been administered. And that's where you get all of the safety data. So you're going to get essentially 2 types of safety information. The first is, gee, that vaccine hurt. For 48 hours, I had a headache and a low-grade fever, and I felt like I had COVID. And, you know, on a small scale, you did. That's your immune system responding to the vaccine. That's normal. It's usually modifiable by taking Tylenol or Advil or something like that. But with every vaccine trial, there are also long-term observations. And so, and that's really beyond the 2 months. These patients who've been enrolled into these trials have been followed for, I think, a median of about 2 to 3 months. So any really long-term effects, long-term side effects like Guillain-Barré, you know, neurologic types of issues, while this is not going to be a frequent occurrence, you can bet that someone of the many thousands of people who get this first wave of vaccine, someone's going to develop an adverse event. And it may not be too pleasant. And, you know, again, this is a public health kind of calculation. Is it better to vaccinate 50,000 people, recognizing that one person may have a serious adverse event and save, you know, 500 lives? That is what vaccinology is all about. It's always about risk and benefit. And so if you look at it in that respect, then yes, absolutely. Vaccine should be administered. If offered it, anybody should take it, unless they're just, you know, categorically, you know, opposed to vaccines in general. And so, you know, I think it's safe, but I can only say that, you know, they follow people for 2 or 3 months, and that's pretty much the safety profile. You're going to read about a couple of patients in Britain that had some really severe adverse events. Again, that's after many thousands of vaccinations those were not reported in the Pfizer study that enrolled 41,000 people, I believe. Okay, so in terms of safety, I think that's all you can say. You can speculate beyond that, but I think that's pretty much going to be the story for right now. The other things other 3 questions are tied into vaccines, and I think these are pretty straightforward and simple to answer. One is, why are the experts saying that we still need to wear a mask even after getting the vaccine? Again, the vaccine is going to protect you from getting the disease. There are 2 variables. I mean, there are 2 things that you don't know. Number one, am I in the 5% or 10% who are not covered by the vaccine, who it doesn't respond, who doesn't give me protection. If that's the case, then I can still acquire the disease and I can give it to somebody else. And since you don't know that, you have to wear a mask. You have to assume that until the vast majority of the population has received vaccines, that you're still susceptible. I'm sure that things will begin to get loosened up once numbers of cases go down, and that's going to happen when we have large numbers of people getting vaccinated. So yes, the same general rules are going to apply, although I suspect they'll be loosened as they begin to see the impact of vaccine. Keep in mind that vaccine is going to be rolled out to the population at large probably by April, May. So we have months more of this to deal with. We're not, this is not going to go away in January. The first rollout is happening next week and for the next few weeks, but it will be months before everybody who needs to get the vaccine gets it. The next question is, does the vaccine totally prevent you from getting COVID or just from getting a severe case? Turns out it's both. If you look at the numbers of people, and this is true of the two vaccines that are, the Pfizer that was approved today and the Moderna that's going to be approved probably next week, they're very similar. They're going to have very similar side effects. They're manufactured in the same way, using the same technology. They both seem to protect people at about a level of about 95%. That's far better than most vaccines that we are commonly familiar with, and certainly the influenza vaccine, which is probably 50, 60% at best. But even at 50 or 60%, it's justifiable to use it, again, because of the mass protection that you get and the fact that you prevent hundreds and thousands of cases with a vaccine that's of limited efficacy. And it varies from year to year because, of course, the virus changes every year. But the numbers look something like this. This is a blinded study. You didn't know whether you're getting saline or the vaccine. 40,000 people, lots and lots of people. I'm gonna estimate, because these are not the actual numbers. I don't have the study in front of me. But let's say among those 40,000 people, 200 people developed COVID. Out of that 200, 190 did not receive the vaccine, 10 did. That's where you get the 95% efficacy. Okay, so it basically prevented 180 cases occurring in the vaccine group. And in addition to that, among all the severe cases, only 10% of the severe cases occurred in vaccine recipients, and I think it was only one. Whereas in the placebo recipients, the number of severe cases was about 10-fold greater than that. So our
church is doing a Zoom thing.
So not only does it prevent cases, but it prevents severity. And then the last question doesn't have anything much to do with the vaccine, but it is important. Is it safe to visit someone's house if you wear a mask and distance? Oh, I think so. I mean, I think that, we're suggesting, absolute, don't visit anybody, don't do anything. I mean, we're not in total lockdown. My personal feeling and my personal behavior is, I exercise caution anytime I'm around anybody that's not my immediate family, somebody that I live with. We're going to have our kids and our grandkids here next week, against CDC recommendation. However, we're all getting tested. Everybody's getting tested before we gather, and we're going to be hanging together while we're in town. So I'm very comfortable with that. But you simply don't know when you're walking into anyone's house, family member or a non-family member. Just as you don't know, an individual's status walking to church or into the grocery store. But if everyone is wearing masks if everyone is keeping their distance, and if everyone is avoiding touching one another, or sanitizing their hands very frequently, then the risk of transmission is very low. It's very, very low, and all the data support that. And that's why if we adhere to these guidelines, then we make this kind of go away even before the vaccine takes full effect. Look at what's happened in our church. I mean, we've been gathering as a group for several weeks or months now. And I don't think that we can implicate gathering at the church as having anything to do with anybody in our community getting COVID. We've not had a point source outbreak. We've not had, an outbreak from being at church, taking communion from the common cup, et cetera. I think, but look at what we're doing. We're all wearing masks, and we're all keeping our distance. The priests are wearing masks. I think this is a good example of what happens when you follow the rules. And in my view, church is a safe place to be. It's not a place we're going to come to get COVID, as long as we abide by those simple measures. Okay, there are a bunch of those are the questions that were submitted earlier on. Go ahead, Father.
I got on the chat here, I got maybe 6 or 7 questions. One group are follow-up questions to the vaccine.
Okay.
So for example, do you have a preference on which of the vaccines, Pfizer, Moderna, the Oxford one? And then my own question, which actually was, I'm taking from someone who talked to me the other day. This person was expressing some reservation about the new mRNA technology that's used in Pfizer and Moderna, and suggesting something like, well, it doesn't actually prevent the transmission of the disease. It only affects the symptoms, and so you could possibly still be transmitting the disease. Anyway, could you say a little bit about the differences between the
Sure. Yeah, the main thing is that these two, the Moderna and the Pfizer, are made very, very similarly. And without getting too technical, we've never used an mRNA vaccine. mRNA stands for messenger RNA. Messenger RNA is that machinery that generates proteins. And that, when you see a picture of the virus, you see this round sphere with these objects sticking out. Those objects sticking out are the spike proteins. Those proteins are what generate immunity. That's what antibodies are made to. So it's, antibodies are not made to an entire virus, they're made to a component of the virus. And so the genius of this is that the vaccine they administer is basically mRNA. It's not actual viral mRNA, it's mRNA that's been generated synthetically. And it's put in a lipid type of carrier. Once it's administered intramuscularly, it's taken up by cells. And within the cell, that mRNA starts to generate proteins, like a viral protein. And then the body develops antibodies to those proteins that are generated in your own cells by this vaccine. And so that's unique. We've not done that before with other vaccines. It's usually a component of the vaccine, of the virus, or a killed virus. And so, that's what's unique about these. And I think it's astounding that you're getting 95% response to those. So I think between Moderna and Pfizer, I don't know that there's going to be a difference. I really don't. The only other vaccine that I have any knowledge about is the AstraZeneca one that was done in combination or in collaboration with the Oxford group. And honestly, their response was 70% in aggregate. If you take all comers, it was 70%. That's more like a typical vaccine. But the beauty of that one is its logistics. It's cheap. It's going to be probably less than $1 a dose for them to, they've had a lot of subsidies, but it'll be less than $1 a dose. It doesn't have to be frozen at, -50 or -70 or whatever the Pfizer vaccine has to be transported at. So logistically, it's going to be a lot easier to administer. It's going to be much, much cheaper. And as to safety, efficacy, there's just not a lot of data that you can look at this point. Those are my thoughts. Was it
okay?
Your question?
Follow-up question here: should a person who's already had the virus still get the vaccine?
Well, you can get the. I think the short answer is yes. I don't think they're going to distinguish. I don't think they're going to ask you unless there's a shortage, unless there's a genuine shortage. I don't think you're going to be asked, "Have you had it?" Because, in truth, now we've seen. Now that this has been going on for 8 months, 9 months, almost a year, there are countless people that have had this infection more than once. And that tells us something. It tells us something about coronaviruses in general, that you can get them more than once. And this is not a mutated form. I mean, this is the same virus. It's not like influenza that's mutating. God forbid that we mutate, that this mutates. This is really, that would really be devastating. But I think what it says about the host immune system is that people don't maintain their immunity to a natural infection for very long. We see this in nature, 6 months, maybe 8 months. And so if the vaccine behaves like a natural infection, you would expect that people might have to be vaccinated every year or two. But that'll never be sorted out until they can follow people long enough in order to do studies, what is their level of protection, et cetera. So, I mean, those are longitudinal studies that won't be, you can't even begin to do them until, next year to see how people are holding up with respect to their antibody levels. It does look, among the studies that are done though, you can see that there's a deterioration of antibody level over time, which is natural. That occurs with natural infections and vaccine together. I mean, both of those, but the question is, how rapidly does it deteriorate, decline, and how sustainable will it be? So those are just unknown.
Can you say anything definitive about any period of time of immunity? For example, is it pretty clear that having it once provides 3 months immunity, 4 months?
Oh, you mean having a natural infection?
Yes.
Having a natural infection, I mean, the interval that we've been seeing has been about 3 months for people who get it once and then twice. Within the same month, it's probably an extension of the same infection. But with a 90-day interval between those two, that's a reinfection. And that's been about what we've seen, 3 to 6 months. And I think it's probably very, very individually dictated based on an individual's immune responsiveness. And that's as variable as there are humans. So it's just completely unpredictable.
All right, another question. If you are immune suppressed, is it still okay to take the vaccine? Absolutely.
You're not. If you're a transplant, if you're a person receiving steroids, if you're HIV infected, if you are receiving a biologic agent, I mean, these are the people that I see all day. And yes, absolutely. So those individuals will be prioritized. They're not being given a live virus. They're not going to be, it's not like yellow fever where you're giving a virus that might disseminate, that might, grow in your system. You're being given simply particles or the machinery to develop antibodies. So this is not an organism that's going to replicate in your body and cause, severe infection. But having said that, you're gonna have a headache. You're probably gonna have low-grade fever. You're gonna feel like crap for 48 to 72 hours, maybe. And if so, you take Tylenol, Advil, or whatever to mitigate the symptoms until you get through that. But you should not avoid it just because you're immunosuppressed. I mean, you look at the US population and there are a ton of people who have immunocompromising conditions. And I don't mean just diabetes and hypertension and COPD and heart failure. I'm talking about either HIV or people who are pharmacologically immunosuppressed for whatever reason. You know, they get medications that are used, you know, as immunosuppressives. That group of people is enormous. And yes, they'll all be on the short list to be prioritized as vaccine recipients.
All right, we got a lot of questions here. I want to make sure I get to all of them. So here's a question about testing. So how accurate are the nose swab next day tests or the rapid test results? And can you test too soon?
Yeah, any of the PCR-based tests, are generally going to be pretty accurate. So the nasopharyngeal swab is your most accurate test. Some of the rapid tests that are not necessarily PCR based, probably the test that Nick Saban had the first time around. I don't know which test they were using. The one that was positive once and then negative 5 times. I don't know. I mean, that probably really was a false positive, but those, some of the rapid nasal assays are, you know, they're better than nothing. They're good for screening purposes. I just had one yesterday, for instance. UAB is doing, you know, they're randomly selecting employees to find out what the prevalence of COVID is in their employees. And, you know, they're using a rapid assay. So, you know, for those purposes, it's really pretty good. But the most accurate one is going to be the nasopharyngeal swab or a PCR-based, less invasive swab. They're also working on assays that are just based on a swish. You do kind of a mouthwash, and they'll do, you know, viral genome in one of those samples. As far as the timing of testing, yeah, timing is important because most people are those who are going to develop COVID, the disease, are going to be positive for the virus a few days before they develop symptoms. That's the whole key to this, is that people are spreading virus rapidly and really, really effectively before they ever develop symptoms. That's why it's so important to wear the mask, because you don't know, you know when or if you're carrying virus. Once you develop virus, you probably have about, I don't know, 5 days maybe before it's going to be recoverable, probably only from your lungs. And so people who've had symptoms for days and days, who go to the hospital and get a COVID test and it's negative, it doesn't necessarily rule it out, because by that time, the only remaining virus is in the wrong place. It's in your lungs. It's not in the back of your throat and your nasopharynx. So yes, timing has something to do. The earlier, the better. If you're talking about, well, gee, I was exposed to somebody who isn't a known positive, and that was 3 days ago, do I want to go ahead and get tested? You know, the answer is you can develop COVID anytime within 14 days after an exposure, and your test may not, you know, you may have a negative test for several days. And so a lot of people feel a lot better if they've gone out and gotten a test, let's say at 5 days, 6 days, 7 days, but it doesn't really help. It doesn't shorten the time of their quarantine, which is ultimately the question. When can I feel safe that I don't have the disease? And the answer is after a meaningful exposure. You know, that's going to be still the 2 weeks.
Okay. Let's see. This is a question I had that I've heard several people bring up. And the New York Times had an article a couple months ago about the tests, the PCR tests here in the US. And it was talking about the difference between the tests here, how the test is calibrated here in the US versus Europe. And it was saying that the test is actually more sensitive here than it is in Europe. I think at 40 cycles in Europe, they're at 30 cycles. And
right.
this might explain people testing positive but not having any symptoms, perhaps not actually being contagious. Do you have anything to respond to that?
All that basically reflects is that's really then a question of sensitivity. Sensitivity refers to, how accurate is the test in predicting who has a true positive. And so with PCR, accuracy may depend on the number of cycles that you run. So the more cycles you have, the more likely you are to pick up very small amounts of virus. And those very small amounts of virus may or may not reflect either contagion or symptoms. And so I think the point being that maybe our positivity rate is driven by the fact that when we're doing the nasopharyngeal swabs and we're doing, the traditional cycles, maybe we're picking up small amounts of virus that are, relatively inconsequential, certainly at least in terms of symptomatic individuals. And so is that the explanation? Is that why we have so many, asymptomatic individuals? Or is it just, the testing pool, the fact that we're much more aggressive about doing testing perhaps than certain other countries? I don't know the answer to that. So it's just another kind of theory as to why our rates are really high. But I mean, the rate to look at is, what do your hospitals look like? And when your hospitals are full, as ours are now, we have over 2,000 people in the state of Alabama hospitalized with COVID. We don't have 2,000 people in an entire year hospitalized with influenza. Then, this suggests that those 30% prevalence numbers that we're seeing now, it was down to 5% or 3%, remember, months ago, and now it's 30%, meaning 100 people come in to get tested for COVID, 30 of them are positive, whereas a few months ago, only 3 were positive. So it's exploding. And and that doesn't have anything to do with how many cycles we're running. So, I think we can focus on that a little bit too much when really we just should be looking at the hospitals, because that's the barometer that tells us how much disease there really is in the community, and what the the social and the economic impacts are going to be, not just with hospital volume and access to care and so forth. It's just all the other downstream effects of having this amount of illness around.
Okay, you mentioned flu. So here's a question. Where are all the flu cases? We are in the prime of flu season, but little to no reported cases. Not quite. There's an interesting study. The flu season occurs in Australia and the Southern Hemisphere 6 months before it gets here. And COVID was prevalent in Australia and in Chile and other places. And where they were wearing masks, flu kind of disappeared, at least this last winter. Now, I would argue that the flu season, we're still at the very beginning of the flu season. The flu season in this state usually hits around February, March. So we're still early. Now, we've had a couple of dually infected people who came in with both COVID and influenza. In fact, we're offering the dual test now. So it is that time. I haven't seen one of these patients personally, so I'm not sure how, I'm not sure that anyone has seen a lot of it yet. But, we're right at the beginning. We're on the cusp of the flu season. I don't think we've begun to see it just yet. But I think what mask wearing we are experiencing and seeing is probably cut transmission pretty significantly. Remember that with influenza, there's a lot more, pre-existing people who've seen influenza before. And, there's already a host of the population has already received the vaccination. So you couple that with maybe decreased transmission, it makes sense that maybe influenza is not going to be as severe this year as COVID still is, with all these non-immune people still walking around. 300,000 cases in Alabama, 500
5 million people, we still got, 4.5 million to go in terms of uninfected folks.
A couple questions here regarding the holidays coming up, and you alluded to that earlier with your family coming. Mm-hmm. So the questions are, do you recommend testing relatives that are coming for the holidays from another state before they arrive here? And the other one is, if you have not had an exposure, however, want to test before getting together with family, how long is a good time to stay away from public places?
Well, I feel like the mayor of Denver, where I'm telling people to do what I say and not what I do. I as much as anybody understand this family business. And we made a decision. Fortunately, my daughter and my son-in-law are both physicians. And so they were the ones who really insisted on it. And I gladly complied with that. I think that getting tested the day before you come with a rapid test and then not being crazy when we get here and just hanging with one another is sufficient. I would definitely test somebody coming from out of state, because you just, or out of town. I would think that would be a reasonable thing to do, particularly if they're going to come and stay in your house. If you're not going to eat outside, if you're not going to distance yourself, and then you can say, well, what are the other risks? Well, a kid away at college, none of those kids seem to be, utilizing any kind of protection. I know Eli Pappas is not, and he's already had COVID. And but I think that the younger the crowd, including school-age kids, young kids, I think the more likely that something like that may occur. Most adults who kind of understand their risk are being, most of them understand it, and they understand wearing a mask, et cetera. But once you start mixing families and especially youngsters who have been in school or college, I think it really means you should consider testing pretty strongly before you get together. What was the other part of the question, Father? I'm afraid
I'm not sure I understood it exactly. If you have not had an exposure, however, you want to test before getting together with family for the holidays, how long is a good time to stay away from public places? I guess, so how long should you quarantine? I'm guessing it's...
I don't know. Personally, I would recommend that if your family's coming over on Thursday or Friday, you get tested on Wednesday. And again, wear your mask, wash your hands and keep distance throughout this time. And therefore just really do your part in preventing, spread within your family and to others.
All right, let's see.
That's the best way for me to answer that question.
If someone has a negative test and still has symptoms after 10 days, how soon should that person get retested?
They should not be retested. The feeling now is that retesting is probably of little benefit. In fact, if you're going to use UAB as a standard, and you kind of have to here because that's where all the COVID experts are, we won't allow you to do another test for 90 days. So if you have a positive test, we don't retest. You can get another test in 90 days, but we don't, we're too often looking for what we might call a test of cure. Like, gee, now I'm negative, I'm okay. The fact is, if you are symptom-free after a documented COVID episode, and you're symptom-free now for several days, and again, the recommendations change, but you have to be 10 days out from your initial diagnosis, but also several days without symptoms. And I can't remember if it's 3, 5, or 7 days. I think it's 3 or 5. But if you are symptom-free following a documented episode, then you're okay to go back into society, the workplace, et cetera, wearing your mask just like everybody else. the distinction between that and the exposure is the exposed person doesn't know when in 14 days whether they might become then that asymptomatic carrier. And so that window of 14 days covers about 95% of what we know now to be, documented infections. They 95, 97% of them will occur within that 14-day window. So that's the distinction.
So let's say you're 10 days out, but you're still coughing.
Yeah.
Does that mean that you should continue to quarantine, that you might be contagious?
Yep.
Yeah.
Yep. Well, in truth, you're probably not contagious, but who's going to take that risk?
Right.
Who's going to take that risk? And so you need to be, when they say symptom-free, they really mean symptom-free. I mean, you don't need to be coughing, no fever, no headache, no myalgias. You really need to be, you're going to feel weak. You're going to have that kind of asthenia. But in terms of just getting out and mingling with society again with your mask, you really need to be asymptomatic for several days. Again, the 3 to 5 days for sure.
You mentioned something a minute ago about now it seems that UAB, for example, won't do a retest until 90 days. Is there anything else that, maybe you want to bust some myths that, maybe people learned early on in this that now we've kind of gone away from? For example, one question here that might fall into this category, I don't know, is it safe to go to the grocery store? Or is it safe to pick up takeout food from your car?
Yeah. You mean in general?
Yeah.
Yeah. I mean, okay. True confessions. We go to the grocery store, but we always wear a mask. We always keep our difference. We go to restaurants, but we go to restaurants where the guys are wearing masks, where the people serving your table are wearing masks. You walk in with a mask. The tables are spread apart. Now, of course, I've read in South Korea that restaurants are now being identified as a hot spot. Well, yes, I understand that, but if you're careful about where you select, and you go into places that really are abiding by the rules, or they're feeding you outside, then yes, those things are reasonable to do, but you have to be just careful and observant. And so therefore, takeout food is fine. I have no problems with takeout food. I have a real problem, unfortunately, with bars, because you can't, go to a bar without wanting to congregate and get close together. If you could go to a bar and sit, far apart from, a group that you want to hang with, then fine. But it's just, it's against our nature. And so I think that we have to avoid situations where we're kind of tempted or forced to congregate in close quarters. And I really think that's the important distinction. So, takeout food, as long, again, as you trust that the individuals who are that you're working with or buying food from are abiding by certain standards. I don't know how you can prove that in the kitchen, but they need to be bringing it out with a mask, and they need to have gloves on, et cetera. Those types of things. Not hard to figure out.
All right, let's see. Have there been any extensive studies that have concluded that certain blood types and Rh factors might have more or less severe cases of COVID?
Too little data. There was a suggestion that people with O-type blood had worse outcomes. I didn't pay a lot of attention to it because it just kind of a interesting observation. I have no doubt that people, as with most other infections, are genetically predisposed to severity. I mean, you can't explain how you can line up 100 people who all look the same in terms of, being, healthy, or same or 100 hypertensives for that matter. And out of that 100, 5 will, or 10, for no clear reason, will get just sick as they can be and require hospitalization. And for the life of you, you can't figure out why, they behave differently or had a more severe illness than, the person next to them. And the answer, as with most of these things, usually if you look at it hard enough, you'll see that they have some genetic predisposition to severity or severe illness with this particular germ. I mean, we know that absolutely for things like tuberculosis. Same is true for TB. If you with a person that has active TB, and they infect 100 people in the room, 10 will come down with symptomatic tuberculosis over the period of life. And those people, pretty clearly from observational studies are genetically predisposed to develop TB. The rest will just have a positive skin test for the rest of their life. So it does seem that that same logic or that same kind of principle seems to follow most infectious diseases. And it kind of explains the variability in how different people respond to infection in a different way. Grandma had a strong immune system. Well, they're probably right. Grandma did have a strong immune system. She had great genetics, and maybe her sister, maybe Aunt Jane had a hole in her immune system that allowed her to, die from TB or die from a virus that everybody else in the family was exposed to. So, I mean, there are genetic answers to most of those questions.
All right, here's perhaps a related question. Is there a specific age group that has to be hospitalized, or does it depend on pre-existing conditions?
I'm just going to get off this. I can't
It's all
take this.
It's all based on symptoms. It's not really an age group. It's really the symptoms that you come in. What will happen if you present to an ER, if you present to an emergency room with COVID symptoms, they're not going to hospitalize you anticipating that you may become ill. They can't afford to do that now. There are just no beds. So, you're going to have a low O2 saturation. That is, the oxygen level in your blood is probably going to have to be down below 95%. Severe symptoms, et cetera. Even if you're 80 years old and you have COVID, but your oxygen saturation is 98%, which is normal, they'll probably send you home and ask you to be observed. And now the bottom can fall out in 24 hours, but right now we do not have the luxury of admitting people who don't need lots of support. So we might have in the past had the capacity to admit people expecting them to get sick, but now we don't have that capacity.
Questions are slowing down. I think I'm just trying to get the last ones.
I got one, Father.
Okay, go ahead.
Jimmy's got one.
I got one. Hey, Pete, thanks for doing this. It's very appreciative and very educational. Supplements, vitamin D, zinc, vitamin C, etc. Everybody's talking about how that helps with your risk. Is there anything that substantiates that?
No, not really. I don't discourage people from taking it. If they believe in it, that's fine. I would discourage you from taking hydrochloroquine. That can be harmful and it's proven not to be helpful. But vitamins and zinc and so forth, it's really hard to say. It's real easy for people to get behind that kind of stuff, natural immune boosters and so forth. And it has an appeal to us because it's non-medicinal, and zinc helps your immune system and vitamin D, et cetera. I would just say I don't know. Think settle. but I think if you feel better taking that, fine. Just don't pay $1,000 to some charlatan who has that to gain. I just would be real careful about that.
And part two of that, we talk so much about the vaccines. What about treatments, Pete? Is there any legitimate treatments as we get this that are helping people get well?
Well, if you look at the mortality of hospitalized patients has dropped from, early in the epidemic, it was 5%. And now I heard today, we had our weekly update today, and we're down to 1%. The problem is the number of people that are dying is still greater because the numbers that we have are so much greater. So the numbers are overwhelming our system. But when you come in, an individual's chance of dying is a fraction of what it was. So what that reflects, Jimmy, is, we've learned a lot about the course of the disease. We've learned a lot about positioning with the ventilator, putting people on their stomachs and so forth. But also, we're given steroids really early. This dexamethasone, they're given steroids very early. And of all the things that we do, isn't it interesting that probably the most important intervention has been dexamethasone, which has been around for 50 years. But it's an anti-inflammatory, and all the damage, all the death is being perpetrated by an overactive immune system, an overactive inflammatory response. So you give people a bolus of dexamethasone and you give them tapering doses for the next 5 to 7 days. You add the remdesivir, the antiviral. I think most of us believe that remdesivir is, it's an okay drug. It's not a game changer. It's really not. The game changer seems to be dexamethasone. And beyond those two, everything else is investigational. We're on our 4th study now, examining different agents and, altering the immune system, altering the inflammatory response. I can't tell you which of those is going to be beneficial. But I can tell you that dexamethasone seems to work. It really does.
And I have one last one, and it's more personal.
No, I'm sorry. I can't tell you that.
You can't tell me that. No, it's Parks, our grandchild, has COVID, and his mom is caring for him, but she's tested negative. But
how old is he?
He's 2.5.
Okay.
And she's tested negative. Should she retest at the end of it when he's feeling better as he is now?
But she has
symptoms.
I don't know. She can retest if she wants to. Reassure herself, I suppose, but she still needs to quarantine. She's going to have to quarantine, and
they're doing that. So,
Stephanie, you're saying that she has symptoms now?
Yes. She has the whole time.
Yeah, I would assume that she is. I would if I were her, I'm going to assume that she's positive, and manage myself accordingly. So
that's what she's doing. We just
remain in quarantine, and for somebody that's had that much exposure, and I don't know how you could take care of a 2-year-old baby and not be positive. And so,
cool. Thank you.
Follow the CDC guidelines. They're good.
That's what she's doing.
Okay.
Thank you.
Father, my pleasure. What else, Father?
All right. I think we're going to try to keep the Tommy Year Out rule of 1 hour. So I think
Can I ask one question? Father, this is Vina. May I ask one question? Pete, do you have any further, you may not have much information since it's so recent, the vaccine being given in Britain, they've reported some allergic reactions.
Right.
Have you heard any more about that?
No, I mentioned that at the beginning. There are a couple of allergic responses to 2 recipients. I think it was 2 recipients in Britain. That wasn't seen among the 40,000 plus that were involved in the trial that was largely done in the U.S. You know, that's we were talking about before. Vaccine trials traditionally are hard to do because not only do you have to vaccinate a lot of people, but you have to follow them for a long time. And invariably, just like with any other medicine, but especially with vaccines, you always uncover less common events. You start rolling it out to the population. Of course, it makes sense. You know, this event occurred in, say, 2 in a million people, but we only vaccinated in the study 40 or 50,000. Well, you know, what the chances of uncovering that? So what you can say when you look at data from a vaccine study, and you know, I would encourage anybody, the data will be it should be generally available and interpretable for, you know, a non-medical person, you know, pretty soon if it's not already. And the major events that are going to be experienced will be seen among the 40,000 people who are vaccinated. And they will include, you know, the local pain, the fever, the headache, maybe some asthenia, that is, you know, just not feeling good, weakness, but those things should dissipate in about 72 hours. And again, for me, I'm going to take the vaccine. I'm going to take it on a Friday. I'm going to try and hope that I don't get too ill in getting it, and hope that by Monday I can go back to work. But I think we should all kind of anticipate that. And are there going to be severe side effects among, you know, 1, 2, 3 in a million people? Absolutely. You can predict that. There will be.
Well, I was concerned because the news bulletin that I heard, and I only heard portions of it, were that some of the physicians there were saying people with hyper reaction to different medications, they were cautioning. Yeah. So I didn't know if there was something further that.
I'm sorry, I don't know, Vina. I can't answer that with any authority at all.
Well, it's so soon, and this was just in the last 24 hours people received it. So,
well, I mean,
you've given us a lot of information that we really need.
All right,
good.
We're entering the lightning round now.
I love it. Okay.
Here we go. I have heard a lot of people in the hospital are low on melatonin. True or false?
They're low on melatonin? You mean no. They're not suffering from a melatonin deficiency.
I mean, I guess the question is asking, is there a correlation between being more susceptible to severe symptoms and...
No, not to my knowledge. No.
Okay. Are we seeing more cases in children?
I honestly don't know. Yes, we are. I'm sure we are. Just because of the sheer volume. One of our fellows is a pediatric and adult ID fellow, and she said the numbers are going up at children's pretty dramatically. I just don't know the severity. I assume they're severe to get into the hospital.
Okay, and then I think final question is from Kathy. My Greek nose is very delicate. I'm hoping to take a blood test before Christmas. Are blood tests as accurate as nasal tests?
No.
No.
No, blood test is just going to tell you that you have antibody. If you want to understand whether you have the actual virus, you're going to have to do a nasal test or some kind of, respiratory sample. The blood test will only tell you if your antibody is positive or negative. That is, whether you've had the virus before or not.
And that would be limited, I would assume, to the last 3 months, whether you've had it.
Yeah, I think so.
All right. Well, when do you expect the vaccine to be widely available? Someone asked. I think you mentioned April.
Yeah.
April.
Well, yeah. I mean, what's going to happen? You're going to start. I mean, the news is all over this. So they're going to offer it to us next week. I mean, the vaccine is being shipped, and we expect to get it. We're going to get 11,000 doses at UAB, and we're going to distribute half of those to surrounding providers and other hospitals. But it's being prioritized for providers, those who see patients, people in the hospital that are in contact with, like housekeeping and so forth, that are in contact with material, and then high-risk individuals, mainly focusing on nursing homes. Those are the people that have the highest rate of serious illness and death. Then there's a second tier that'll be high-risk individuals in general, and I'm not sure how that's defined at this point. And then there's a third tier. This is what I've seen so far. The third tier includes people who are not at super high risk, but maybe on the basis of age or hypertension or diabetes. That will be a third tier. And, so if we start next week or the week after, you can assume that, by January, most healthcare workers will have been vaccinated, those who are being vaccinated. And then I would imagine phase 2 and phase 3 will roll out. And I would imagine the way they're going to pour out this vaccine, these vaccines, thankfully there's several sources. I would imagine that most people have access to the vaccine if they want it by, let's say, somewhere between April and June. Is that the end of it? Is that the end of this epidemic? I don't know. I think we have yet to see that. But it's going to be a major, it'll have major impact. If we can convince, 50, 60, 70 or more % of the population to take it, we'll be, next summer will be a different summer than what we just experienced.
All right, final question. Would an ion air purifier help keep your family safer at home?
An ion air, I don't know what an ion air purifier is. I'm sorry.
I think it's a brand, perhaps, an ionizing air purifier. Okay.
I'm presuming it's one that selects out really small particles. And I would say, I would probably invest in something else, because these particles, these droplets, hit the ground pretty quickly. They don't remain aerosolized for a long time. And I would think that if I was going to invest some money in something, I would probably invest it in something else. I'd probably buy a box of masks and
up your stewardship pledge.
Yeah, up my stewardship pledge. Do that kind of stuff with the extra cash that I have on hand.
Is it if people want to help? Someone's asking, is there a need for volunteers to help distribute the vaccine or anything like that?
It's a great question, and it's a wonderful thought. I think that right now there's such a this is such a priority. I think that right now they're only going to be administered in certain places right now. I saw where someone had suggested maybe the church can get involved in administering it. It'd be a great ministry, but I don't know how that's going to roll out. I think they're probably going to keep this pretty tight to the vest, so they can basically keep up. You need an initial vaccine and then a booster for all of these. And so, it means you have to get the second one if you're going to be protected. Sort of like your kids when they get in their measles vaccines, measles, mumps, and rubella, they get 2 or 3 of those. So if you want adequate protection, you're going to need to get 2. It's going to require follow-up. Probably too much to ask of volunteers. Be health records and so forth involved. And so I think probably, certainly early on, this is going to be administered pretty tightly, I suspect.
All right, thank you so much, Pete. I tried to get to all the questions. There may have been some more detailed ones. Is there, if people have more concerns and need to talk to you, are you open to that?
Anytime, sure.
Okay. All right. Don't be shy. Reach out to Pete. He's very generous with his time and his expertise. This is a way of sharing your time and talent with us. So we thank you. God bless you.
Okay. All
Thank
right.
you, Pete.
Thank you, guys. Thank you.
Thank you, Pete.
Right. Thank you.
Great job, brother.
Good
All
night.
right, guys.
Thank you.
Thanks for arranging this.
Thank you, Father.
Thank you.
Bye-bye.
So much.
I really appreciate your time. Thank you.